So, ladies and gentlemen, I guess I'm the last speaker at the end of a very long day, and I'll try not to keep you too long. And first of all, I'd like to say that it's a privilege to be asked to participate in this. Certainly, the people in the audience and the people that have spoken before me have a greater deal of expertise than I have. So, let me reflect on the view that I have as both an academic chair of a university department and a hospital chief that has more clinical and fiscal responsibilities. What are the deliverables that I'm expected to bring to our boardroom? Obviously, everybody expects clinical excellence. In an academic institution, there is a responsibility to clinically innovate, and that means that you don't do things by dogma. In fact, you do things by asking yourself, how are you doing them now? And how could you do them better? And then how do you go from where you are to where you want to be? And you do that by generating and reviewing and implementing new knowledge that is attained through research. As well, any academic program has a responsibility for teaching. And one of the opportunities that decreasing variability brings is the idea that you could bring to your students the concepts of a consistent message that is based on evidence that really informs the way they should be practicing their surgery. And then finally, you have to be responsible in the use of resources. And a lot of people have talked about the cost, the length of stay, the other resources that are being inspected increasingly and are highly constrained. So the academic mission of the Department of Surgery, if I could expand a bit, means we teach a whole group of people, all the way from medical students to practicing physicians, as well as teaching our faculty how to develop their own skills. We have a research agenda, and the research agenda in a department tends to be quite broad. So there are aspects of basic science. Of course, there's clinical research that includes things that we've spoken about, such as quality outcomes, safety, processes of care, healthcare economics. We have research in how do we teach, how do we innovate, and how do we do discovery. And then faculty development really means what is the opportunity that we have to build up our faculty members so that they can succeed in their own careers through promotion and national and international recognition. And I say these things because I think it lays the groundwork for how we might talk about it. Now, if you look at research and clinical research, as well as education and simulation, in fact, these two components are really essential for implementation science. And as you've heard before, the barriers of taking evidence to practice are implementation science. So you need to generate the evidence, but you need to also look at how can you utilize modern aspects of teaching and simulation to actually convince people and actually bring the theory to reality. Now, if I put on my other hat, which is that of a busy hospital clinical chief, we're asked to provide value. Value is a word that you'll hear over and over about. What does it mean? It can mean many different things, but it's a ratio of some sort. It's a ratio of a deliverable over the cost of delivering that. And in this case, I'll talk about clinical excellence with maximal efficiency in use of the resources. What is clinical excellence? Well, clinical excellence is safe, excellent outcomes that result in high patient satisfaction. I mean, this is simplistic. What is efficient? We want to minimize the resources that are tight. So we want to make sure that the hospital beds are used effectively. People are in the hospital when they need to be, but they're not in hospital when they don't need to be. But on the other hand, as said before, we don't want to trade that off with those patients bouncing back to the emergency room, be readmitted, or being a burden on the caregivers in their homes or their community. So we want to make sure that the resources that are in place are used appropriately. And I think very importantly, look at where is the variability in the utilization of resources in the care of a problem that's relatively standardized. And one of the things when you look at implementation is you can address individuals that are high outliers because they don't adopt evidence. So one of the things that we want to do is really look at where is the variability, because variability provides opportunity. And I think it also helps inform a good teaching program. So what do enhanced recovery programs bring from the perspective of department chair? First of all, as said before, it brings the people involved in the care of the patient together in a team with a single goal in mind. And that goal is to be focused on the patient and to use their communication skills to take full advantage of the individual talents and skills of each of the people involved in the process of care of that individual patient. I think it is also an opportunity for the surgeon's role to be enhanced and to really extend much further than our role in the operating room. And as we've evolved to become more and more technologically focused with a lot of the innovations and the excitement that has brought to our surgical care, perhaps we've not fully engaged in the pre- and post-operative care. If anything is going to happen substantially, the surgeon has got to be part of that process. Not alone, but I think the surgeon cannot abrogate that responsibility. As was said earlier, we need to practice evidence-based medicine, and that means challenging dogma. And there, as Tony said, I don't think there's a better way of doing that than bringing the evidence to the table. And most importantly, evidence of the outcomes in your hands, in your institution, because you cannot always assume that evidence that is accrued elsewhere will be able to be reproduced in your institution. Perhaps you should be able to achieve best practices, but you don't always do that, and I think it's really important. So I think that if you can do that, then you could use your best evidence and provide the consistency that you want in patient care. What about the academic opportunities? Well, clearly we don't have all the evidence we need to populate the pathways and the processes of care. In areas like colorectal, we've got a large body of evidence. In other clinical areas, we're somewhat lacking. So there is a huge opportunity for creation of new knowledge by identifying where our evidence gaps are and really focusing our investigations in areas that are going to be translatable. And as surgeons doing research, I don't think that there's anything that we could contribute more than translational information. Once we start to do that, then we need to look at what are the outcomes that we should measure. Now, you know, there may be some debate about whether it's outcomes or processes or what is the interaction between the two that we need to do. But those outcomes need to be reflective of the values that are relevant in that particular care map. So the outcomes of a colectomy may be very different than the outcomes of inguinal hernia, but there is still an opportunity to enhance recovery in patients with inguinal hernia. We just have to define what recovery means to that individual patient and how we are not achieving those expectations. What are the things that determine that? And then address our efforts where we're going to get the most bang for the buck. And those types of metrics can be developed in a way that they're reliable, valid, meaningful for the individuals, and really help drive the program. Implementation science is a real challenge, and this is where leadership is important. I think that department chair is in a great position to really influence the corporate people in the institution by taking the information that we are starting to accrue now and making it sound like it's so obvious that this needs to happen, and trying to get from them the type of investment that you need in order to accumulate the data, have the audit people, etc. And speak their language as well as the language of the clinicians. So I think that that is really what's going to allow you to go through the hurdles of implementation. If you have the corporate people behind you, you have the chair behind you, you have advocates within your clinical groupings, anesthesia, nursing, physio, PT, etc., then you're likely to be able to start to move the needle. And I think as you start to move the needle, people don't want to be left off the train. It then gives you the opportunity to start to report on value, on economic impacts and the use of resources, and to identify those people that are laggards and really start to put some peer pressure on them. And then finally, it gets back to what I was saying, as you start to do that, it gives you a curriculum that you could start to teach people, and that involves everybody in the chain of your educational care, including the patient. And that means that your message is consistent, the patient knows what they're going to expect, the house staff knows what they should be doing, and everybody on the team is aligned. Enhanced recovery programs enable your clinical mission because it allows you to actually advocate for the value of a surgical option. The more value, the more bang for the buck you get, the more competitive surgery is against pharmacological treatment, in fact. We're providing a durable, effective care through a single moment of intervention. As you can decrease the toll that that moment has on the patient, you start to prejudice the care in a direction that makes surgery even more attractive. It also allows you to leverage the benefits of minimally invasive surgical techniques. So I think, as Tony said, MIS techniques are helpful, enhanced recovery programs are helpful, but they are synergistic. And I think if you're going to ask to invest more money in MIS, you can more than take advantage of the rewards that you create through your enhanced recovery programs. I think one of the most important things is that it changes the environment in which you work and creates an environment of collegiality and respect, and that is priceless. And finally, it engages the patients in their care. Patients feel very powerless, and when you speak to patients that have gone through this process, and I've spoken to physicians, administrators, etc., they feel that this is extraordinarily enabling for them. They feel satisfied, and they feel that their outcomes are encouraged. So the opportunities are, you can advance the academic career of those people that jump on the bandwagon, and those people that are highly clinical focused, they really have an opportunity to do something academically that is going to be meaningful. We embed evidence-based practices in what we do as much as possible. We change the teaching model to focus on the broader trajectory of care, and we recognize and improve the quality of clinical research. So I think to close, the final steps are to really get a better understanding of what we actually do. I do think linking processes to outcomes are important because it allows you to identify what are the processes that are important and what are the outcomes that we have not been able to optimize. It defines a new research agenda by looking at the gaps that I said before, and the whole process of implementation science that we're learning here will apply to any area where there is a lag between evidence and practice. So I just would like to end by saying that as an organization, SAGES is really engaged in this. We feel that this is a way of truly expanding what we do. It's patient-centered, and I just want to thank everybody who participated in the course today for their input and their good work. Thank you so much.